I would like to thank you for waiting for me and thank the organizing committee for inviting me here today. I would like to support that all drug-eluting stents are not the same. And, oh, is the mouse? Okay. And I have no disclosures relative to this presentation. However, I would like to disclose that when Manos Brilakis emailed me and asked me to give this presentation, I want to ask him if I can take the other one, if all the stents are the same. However, I felt that it was probably taken. So first generation drug-eluting stents were definitely not ideal. They weren't healing well because of thick struts, thick, durable coating, high drug dose, and high polymer load. And that led to uncovered struts, hypersensitivity, malapposition, leading to neoatherosclerosis and late stent thrombosis. And that led us to try to find the second generation drug-eluting stents that do deliver anti-proliferative drugs, but from a more biocompatible coating. So what about the second generation drug-eluting stents? Are they all created equal, or some second generation stents are created more equal than others? And by looking at this diagram, you see all the contemporary drug-eluting stents, and you realize that there are many differences between them. They differ in strut thickness, they differ in the durable or bioabsorbable polymer, different drug-eluted, as well as different alloy platform, flexibility, and conformability. Obviously, the main players here in the market is the durable polymer-coated stents, which is the Xience by Abbott, the Resolute Onyx by Medtronic, and then the bioabsorbable polymer-coated stents, the Synergy, and the newer player in the market, the Orsiro stent with the ultra-thin struts that you will hear about, 6 to 1 microns. And I do not live in Canada, where probably the patients eat salads and drink kombucha. I work in Houston, Texas, and people there eat fried chicken and drink sweet tea, most of them. So visibility of the stents, at least for me, is definitely an issue. And we know that the platforms that are made from a cobalt chromium alloy has poor radiographic visibility. And someone can argue that with the new OCTs and IVUSs, we don't really need to see the stent that well. However, we've all been challenged, I believe, in patients who are obese, when we're trying to treat bifurcation or a calcified lesion, or even when we want to assess our stent expansion by eye before IVUSing and seeing our stent expansion. And I will agree, this is a 20 trial that was presented just earlier, a randomized trial of 1,709 patients that presented with NSTEMI or angina. And as you heard, in 5 years, all the patients head-to-head, zotorolimus versus the everolimus drug-eluting stents, the patients did great. However, I do believe that there's always a room for improvement. If it's 8% target lesion failure at 5 years, we can always get that lower. And for these drug-eluting stents, the durable polymer stents, neoatherosclerosis definitely remains a concern. And we see one of them after 24 and 36 months, what's the presence of neoatherosclerosis. And how about this strut thickness? Are they thrombogenic or not? And how much do they contribute in the target lesion failure in the long term? And you definitely see, how much more thrombogenic are the thicker struts as compared to the thin ones. How do all these translate into data? And let's go in the BioFlow 5 trial, which was a randomized trial of 1,334 patients, randomized the Orsiro versus the Xience. Of note, this trial had no STEMI patient, but it did show that in 1 year, the Orsiro stent had lower target lesion failure and target vessel-related MI as compared to the Xience stent. And this difference did persist through 2 years, favoring the treatment with the bioabsorbable serolimus-eluting stent as compared to the durable polymer. What about the risk of MI? This was a meta-analysis of 6 randomized controlled trials of 6,949 patients that basically compared the Orsiro stent versus all the durable polymer drug-eluting stents. There was no significant difference in stent thrombosis. There was no difference in cardiac mortality. However, the group with Orsiro stent, the risk of myocardial infarction was significantly reduced. So, do we have a winner? Do we just start putting Orsiro on everybody? Do we know that? Well, we don't know it yet. And in this Bionics trial, which was, again, a non-inferiority trial of 2,488 all-comers. So remember, the prior trial had no STEMIs. This one is all trials, including STEMI patients, including patients coming with unstable angina and STEMI. And they were randomized to Resolute, Onyx versus Orsiro. And they followed them in 1 year. And you all see that target lesion failure, cardiac death, target lesion revascularization, MI, they did exactly the same. However, the most striking difference here was in the frequency of stent thrombosis, where the Orsiro stent was statistically worse than the Resolute. Looking a little bit why would that be the case, number one, as I mentioned, there was a high proportion of patients with acute coronary syndrome, more than 70%, and it was a higher percentage of people with bifurcation lesion. So maybe for the Orsiro stent, we need to see a little bit further. Is it a good stent for bifurcation lesions or not? Is it a good stent for acute coronary syndromes? And there are ongoing trials like the BioSTEMI that they're going to answer these questions, but there is something to have in the back of our minds. And then one more, the BioSense trial, 2008 patients presenting with all-comers ACS as 20% STEMIs, randomized designs versus Orsiro, and followed for 5 years. And again, they showed the similar target lesion failure, MI, death, revascularization. Both stents perform wonderfully. However, in the Orsiro stent population, there was a higher incidence of all-cause non-cardiovascular mortality. Very curious why. It's driven by cancer in these patients. And this is something that, you know, the future trials would also like to see some more. Is there an absolute winner here? No, but I do believe we have the same way we have different patients, the same way we can use our stents and use different stents for different stent population. Thank you.